Today I'm going to discuss about respiratory system and basically anatomy of the respiratory system. First of all, I will discuss about nose, or you can say nasal cavity. Then we will discuss about larynx, trachea, lungs, bronchopulmonary segments, and at the end we will discuss about pleura. So let's discuss from the very beginning nose. If we talk about nose, we should think two things about nose. First of all, external nose. External nose is formed by bones above, which bones making, you can say, the above side of the external nose, that are the frontal process of the maxilla and nasal part of the frontal bone. Okay, I can show you. First of all, frontal process of the maxilla. You can see this is the maxilla bone, and here we have frontal process of the maxilla, and then we have nasal part of frontal bone. This is the nasal part of frontal bone. This is the frontal bone, and this is what our maxilla. It is the bones making the above or superior border of the external nose, and below side or inferior side made by plates of hyaline cartilage. Plates of hyaline cartilage. Then we will talk about nasal cavity. We have right and left nasal cavity or nostrils separated by a nasal septum, and that nasal septum formed by three structures. First of all, septal cartilage, vomer bone, and ventral plate of the ethmoid bone. So these three things, they join together and make nasal septum that will divide the nostrils into right and left nasal cavity or into two nostrils. Then after this nose, the extension of the nose. Nose extend from nostrils from the frontal side and goes backward behind till the concha. Okay, and then let's discuss about some boundaries like floor, roof, and lateral walls. The floor of the nose is made by palatine process of the maxilla and horizontal plate of the palatine bone. This is the same bones which were making what? That were making roof of oral cavity, and floor of the nasal cavity formed by the same palatine process of the maxilla bone and horizontal plate of the palatine bone. Is that clear?
Yes, sir.
If we talk about the roof of the nasal cavity, it is made by four bones. Number one, sphenoidal bone, sphenoidal body. It is also called sella turcica. Superiorly, house for the pituitary gland, master gland. But you can see inferior part of the body of the sphenoid bone that is making roof of the nasal cavity. First of all, sphenoidal body or body of the sphenoid bone, a bad shape or a butterfly shaped bone, making the base of the skull. Yes. Then we have cribriform plate of ethmoid bone, which were having the cribriform plate foraminas and cristagalli.
Yes,
inferior to the cribriform plate that is making the roof of the nasal cavity. Then we have frontal bone and nasal bone. So these four bones are making roof of nasal cavity, and floor of the nasal cavity, the same bones are making the roof of oral cavity. Impressive. And lateral wall of the nasal cavity having three projections from the lateral wall. These projections are called conchas, and space between these conchas are called meatus. Now you can see this diagram. This is inferior nasal concha, middle nasal concha, and superior nasal concha. Three projections. We are talking about lateral walls of the nasal cavity. These have three projections called conchas, and space between these conchas are called meatus. Okay, if I can show you, this is superior nasal concha, middle nasal concha, inferior nasal concha. The space present below the inferior nasal concha is called inferior nasal meatus. The space present between middle and inferior nasal concha is called middle nasal meatus. And space between superior and middle nasal concha is called superior nasal meatus. And space present above the nasal superior nasal concha is called sphenoethmoidal recess. So these are the landmarks. We are talking about anatomy only. And okay, let's discuss about some openings. First of all, sphenoethmoidal recess. Sphenoethmoidal recess, this place, it is giving opening to the sphenoidal air sinus. Sphenoidal air sinus open at the sphenoethmoidal recess. And this sphenoethmoidal recess is lined by which mucous membrane? Olfactory mucous membrane, which is required for the sense of olfaction. And we will discuss about this in detail when we were talking about cranial nerves, specifically olfactory nerve. The sense of olfaction starts from this sphenoethmoidal recess, from the olfactory mucous membrane. And Okay, one thing more. The mucous membrane present above the superior nasal concha is olfactory mucous membrane, and the mucous membrane below the superior nasal concha from here to here, that is respiratory mucous membrane.
Yes.
Is that clear? This
Yes,
is the
sir.
respiratory mucous membrane, the membrane present below the superior nasal concha. And above the superior nasal concha, we have which mucous membrane?
Olfactory.
Olfactory mucous membrane. Okay. And there is no fun in telling that the olfactory mucous membrane have a function related to the olfaction, and respiratory mucous membrane hence has a function related to the
Respiration.
Respiration. Very nice. And then now let's discuss about some meatus. These things. Superior nasal. Okay, we have discussed about this thing now. That sphenoethmoidal recess. First of all, sense of olfaction. Number two, opening for the sphenoidal air sinus. One is sense of olfaction. Let me do it. Sense of olfaction, like olfactory nerve fibers are starting from here. Sense of smell of flower or a perfume. And the second thing is opening for the sphenoidal air sinus. Superior nasal meatus, opening for the posterior ethmoidal sinus. Only one opening. For your kind information, it is enough for you. One opening in the superior nasal meatus, that is opening for the posterior ethmoidal recess. Posterior ethmoidal sinus. We have three ethmoidal sinus: posterior, middle, and anterior. Posterior ethmoidal sinus opens at the superior nasal meatus. If we talk about the middle nasal meatus, opening for the anterior ethmoidal sinus, middle ethmoidal sinus, maxillary sinus, and frontal sinus. So there are four openings over here. 1, 2, 3, and 4. One for the middle ethmoidal sinus, anterior ethmoidal sinus, frontal sinus, and maxillary sinus. Let's discuss about the last but not the least, inferior nasal meatus.
Inferior nasal concha.
Inferior space present below the inferior nasal concha is called inferior nasal meatus, having opening for the nasolacrimal duct. Nasolacrimal duct. Over here. So one opening over here. Now let's discuss about some clinical. Okay, before clinical things, the medial wall of the nasal cavity formed by the nasal septum, and we have discussed there are three parts or structures which are making the nasal septum: septal cartilage, vomer, and vertical plate of which bone? Ethmoid bone. Let's discuss about some clinical feature related to the epistaxis. What is epistaxis? Nasal bleeding or nose bleeds. And it happens due to the arterial bleeding or venous bleeding. More specifically, septal branch of the sphenopalatine or facial artery or veins are involved in epistaxis. Last but not the least, we have complications of nasal infection. If there is an infection to the nasal cavity, it will spread to the sinuses. It will spread to the paranasal sinus infection called sinusitis, maybe frontal or maxillary or ethmoidal. After the nose, let's discuss about larynx. As we know, after the nose we have nasopharynx, oropharynx, and laryngopharynx. Below the laryngopharynx and above the trachea, we have sphincter-like projection or a anatomical structure called larynx. It is sphincter responsible for the voice production. And present up to this larynx we have hypopharynx or laryngopharynx, and below or down to the larynx we have trachea, our windpipe. Okay, there are 5 cartilages you should not forget in your life if you are talking about larynx. First of all, thyroid cartilage, cricoid cartilage, arytenoid cartilage, corniculate, and cuneiform. If you can zoom in because of the green in color, so it will be difficult for the viewers. Okay, first of all, thyroid cartilage. It is the largest cartilage. These things, we are talking about anatomy only, na?
Yes, sir.
So this is the largest cartilage called thyroid cartilage. It is having 2 lamellas, and these 2 lamellas having superior and inferior cornea. That's it. Then we have cricoid cartilage, which is present below the thyroid cartilage, and it articulate with the inferior cornea of the lamella of the thyroid cartilage, and it is attached posteriorly with the arytenoid cartilage. We have arytenoid cartilage, which are 2 in number, pyramidal in shape, and articulate with the cricoid cartilage posteriorly. And obviously if cricoid posteriorly attached with the arytenoid, then obviously the arytenoid interiorly attaching with the cricoid. Okay, then we have corniculate cartilage, which is cornical in shape. And before we are going to the corniculate, arytenoid cartilage have apex, base, vocal process, and muscular process. Corniculate cartilage is conical in shape and has been attached to the arytenoid cartilage. Last but not the least, we have cuneiform cartilage, which is a rod in shape, the rod-shaped cartilage, which strengthens the epiglottic fold. And let's discuss about now laryngeal fold. There are two types of laryngeal fold: vestibule laryngeal fold and vocal fold. Vestibule, it is a fixed and pink in color, and vocal folds are mobile and white in color. So that was about larynx. I think it is enough for anatomy. After the larynx, let's discuss about trachea, because after the larynx we have trachea. Trachea, it is a starting from the low respiratory tract. We have upper respiratory tract and low respiratory tract. In upper respiratory tract, start from the nasal cavity till trachea, and from trachea, low respiratory tract starts. So low respiratory tract starts from the trachea and it extends from the C6, cervical vertebra number 6 or cricoid cartilage, and this is the most narrowest part of respiratory tract in the children less than 10 years of age. Less than 10 years of age, this part is most narrowest part of the respiratory tract, and this cricoid cartilage or C6 cervical vertebra starting from the trachea present just 5 centimeter above the jugular notch. We have jugular notch over here, so above the jugular notch is present 5 centimeter above, and it extends till the T4, thoracic vertebra number 4 in the thorax. So that is you can say the starting and ending point of the trachea. If you talk about the length of the trachea, it is 10 to 12 centimeter in length in adult and 4 centimeter in diameter. Okay, let's discuss now. Not 2 centimeter obviously. The adult trachea length is 10 to 12 centimeter long and 2 centimeter in diameter. As compared to newly born baby, the length is only 4 centimeter and diameter is 3 millimeter. And with each year, there will be increase of 1 millimeter in diameter. Okay, before we go into detail about the anterior, posterior and lateral relation of the trachea, let's discuss about a terminology called anatomical dead space and physiological dead space. Anatomical dead space is nothing just our respiratory tract area covered by your covered by the air which is not involved in respiration. And physiological dead space, the air inhaled in the respiratory tract not involved in respiration, or you can say exchange of oxygen and carbon dioxide. So this is anatomical dead space and physiological dead space. Anatomical dead space is just a respiratory tract area covered by your, you can say, filled by the air, not involved in exchange of gases. And physiological dead space are the inhaled air which comes in contact with the respiratory tract but not involved in exchange of the gases like oxygen and carbon dioxide mainly. Then we will talk about some relationships of trachea. The anterior wall of the trachea, you can see the content present anterior to the trachea. You can just zoom in. Left common cavity, these things you have to learn by heart. So anterior relationship of the trachea are with the left common carotid artery, brachiocephalic trunk, left brachiocephalic vein, arc of aorta, deep cardiac plexus, isthmus of thyroid gland, which is present in front of the second, third and fourth ring. We talk about the posterior relationships of the trachea. Posterior to the trachea we have esophagus, and left and right recurrent laryngeal nerves. These are the nerves, when you do a thyroid surgery, most probably chances are that you will injure these recurrent laryngeal nerves and it will lead to the hoarseness of voice. Yes, sir. Due to it is a complication of thyroidectomy because it is just having a close proximity to the thyroid gland. So जब हम thyroid काटते हैं तो कुछ सर्जन ये nerve damage होती है, it will lead to the hoarseness of voice, which is present posterior to the trachea. Let's discuss about the lateral relationships of the trachea, right side and left side. On the right side, we are obviously having right lung and pleura, right brachiocephalic vein, shared vena cava, right vagus nerve and azygous vein. And on the left side of the trachea, we have arc of aorta, left common carotid artery and left subclavian artery. Now let's discuss about hyaline cartilage. Hyaline cartilage is 15 to 20 in number, a horseshoe-shaped, incomplete rings. 15 to 20 in number, and they are required for the tracheal patency. And these incomplete rings are being covered or filled by the muscles posteriorly. Tracheal muscles fills these gaps posteriorly. Let's discuss about carina. What is carina? It's not carina,
Katrina.
or a Katrina cap. It's carina, you can say Latin word means keel. It is a hook-shaped process, and bifurcation. Obviously, the trachea bifurcate into right and left main bronchus or primary bronchi behind the manubrious-sternal joint or angle of Lewis present at the lower level of T4, upper level of T5. So you can see over here, this is the manubrious-sternal joint. This is manubrium and this is manubrious-sternal joint. This one. This is also called angle of Lewis, present at the level of lower border of T4 or upper border of T5, and bifurcation or carina present just posterior to this angle of Lewis. Okay, bifurcation behind the manubrious-sternal joint, angle of Lewis, lower T4 and upper T5 level, and downward or backward projection of the last inferior tracheal rings. Obviously, we have tracheal rings 15 to 20 in number, and last tracheal rings will go downward and backward and divide into right and left principal main bronchus. And the distance of carina from the incisors is 25 centimeter, and if we mark the distance from the nostrils, it is 30 centimeters carina. And there are two important things: functional importance and pathological importance. Functional importance of the carina is mostly sensitive mucosa, having sensitive mucosa, and it will initiate the cough reflex. Most importantly, involve the postural drainage. What happens if the person is lying down on the left side? Okay, then the mucus from the right main bronchus is more dilated and shorter, so the mucus will go towards the carina, and carina is more sensitive, and it will initiate a cough reflex that is called postural drainage. And it will, you can see, it will clear our respiratory tract. And if we talk about pathological importance, it is visible at the sharp sagittal ridge. What is sagittal ridge? Sagittal plane.
Yes, sir.
So the sagittal ridge, sharp sagittal ridge is visible. And if you want to visualize the internal structure of the trachea in bronchoscopy, then it is also very helpful. Pathological importance. This is the pathological importance. And 25 degree and 45 degree. I can show you if I can remove this thing. Simply, this is trachea. Yeah. This is trachea. This is carina. So right side is, I'll do like this, more wide as compared to left side. Here we have carina. This is, you can see, L4 level. Angle of Lewis. Are you with me?
Yes, sir.
So this is right side here, and this one is left side.
T4.
Sorry. Thank you. T4. Thoracic vertebra 4, angle of Lewis. Obviously, lower border of T4 and upper border of T5. Right side is the length of right side of the principal main bronchus is 1 to 2.5 centimeter, and the size of the left main bronchus is 5 centimeter, and is more in diameter. You can see, and this is narrow in diameter due to having wider diameter and shorter length of the right main bronchus. Right lung is most vulnerable to having any kind of infection, or it is more dependent part of the you can say both lungs dependent side. And we were talking about what? Yeah, this
Carina.
carina. Then in bronchoscopy there is a sagittal section for the sagittal ridge for the pathological importance of the carina. And we are talking about angle, obviously. 25 degree for the right side and 45 degree for the left side.
Yes.
If we improve it again, like this, it will be like this. Let's make a midline over here. It is 25 degree, and that is
45.
45. You can see. So that's the difference in the angle of the carina. Now let's discuss about lungs. They are spongy textures, structures, and if we talk about the color of the lung, in young people it is brown and grey in color, but due to inhalation of the carbon particle, this brown and grey coloration of the lung converts into mottled black color. Okay, and if we talk about we will differentiate between right and left lung later on. There are three surfaces of the lung: costal surface, mediastinal surface, and diaphragmatic surface. Costal surface is obviously the anterior surface. Costal surface is being associated with the ribs and the intercostal space. Then we have mediastinal surface. Obviously, this is the central surface we have few cavities, right? Cranial cavity, thoracic cavity, abdominal cavity, and pelvic cavity. And there is a one specifically a specific cavity which is present within the thoracic cavity, that is mediastinal cavity, present in the center, which divides the right and left lung. So one is surface is costal surface associated with the ribs and intercostal space. Another surface is mediastinal surface associated with our mediastinum, and third one is diaphragmatic surface. Obviously we have diaphragm muscle over here. So then we have three borders also, interior border, inferior border, and posterior border. After these border, let's discuss about some parts. Apex and base of the lung. The apex of the lung is present superior end of the lung. It's also called superior end of the lung. It extends to the neck root, and more specifically it's covered by cervical pleura and suprapleural membrane. And apex go upward. We talk about the first rib, it will go 5 centimeter up to the first rib, or 2.5 centimeter above to the medial end of the clavicle. Okay, then base, lower semilunar concave surface, and it rests on the dome of diaphragm, and it is having one main bronchus and one pulmonary artery and two pulmonary veins. If we talk about the root of the lung, it is a short, broad connection between medial surface of the lung and mediastinum, and root of the lung present at the level of T5, T6 and T7, and it consists of few structures which leave and or enter at the hilum of the lung. Okay, now we will compare and contrast between right lung and left lung. Right lung having two fissures, horizontal and oblique fissure. If I can show you, right lung and left lung. Suppose this is our right lung, and here we have left lung. So we have like this, like this, like this. This is right lung, and here we have left lung. Obviously we have trachea like this and carina like this. Okay, just to understand. So we have right lung, we have two fissures. One is oblique fissure, another is horizontal fissure. Then we have three lobes: superior lobe, middle lobe, and inferior lobe. And it is right lung is shorter, broader, larger, and heavier, about 700 grams weight of the right lung. And the interior surface of the right lung is straight, and there are few mediastinal structures. Obviously here we have mediastinum also, na? So there are few mediastinal structures. Which mediastinal structures are associated with the right lung? First of all, right atrium, superior vena cava, inferior vena cava, azygous vein, esophagus, trachea, right phrenic nerve, right vagus nerve, right brachiocephalic vein, and right sympathetic chain. Then let's discuss about the left lung. Left lung having one fissure, only one fissure, that is oblique fissure. There is no horizontal fissure in the left lung. Having two lobes, superior lobe and inferior lobe. Okay, and then it is larger, narrower, smaller, and lighter, almost 600 grams. You can see this right lung is almost 100 gram heavier than the left lung, or you can say the left lung is 100 gram lighter than the right lung. And left lung, the interior surface of the left lung is interrupted due to the cardiac notch. Here we have cardiac notch, so interior surface is interrupted, and there are few mediastinal structures with the left lung, like over here. Mediastinal structures like left lung, left ventricle, left descending thoracic aorta, left ascending aorta, left arc of aorta, left esophagus, left phrenic nerve, left vagus nerve, left sympathetic chain, left common carotid artery, and left subclavian artery. जितना याद होता है कर लें, जितना कर सकते हैं कर लें, सारा कर लें तो best है. So these are the difference between right lung and left lung. Now let's discuss about bronchopulmonary segment. This is the most anatomical, functional, and surgical unit of the lungs. There are 18 to 20 in number, and 18 to 20 in number. Right lung have 10 segments, bronchopulmonary segments. Left lung may or may have 8, 9, or 10 pulmonary segments. Let's do it at 10 only, and it is having associated with the surgical resectable. Just like we have discussed about liver, right? We have how many segments? 8. The importance of the 8 segments in order to diagnose, more specifically in order to remove any kind of trauma, tumor, infection segmentally. So same is true with regard to the bronchopulmonary segments also. So surgical resectable. If there is any problem with any of the segment, just remove that segment only. Don't try to intervene or touch other normal bronchopulmonary segments. Then it is separated by adjacent segments by the connective tissue septa. All these segments are separated together with the help of connective tissue septa, and it is supplied independently by the segmental or tertiary bronchus and tertiary branches of the pulmonary arteries. And why they are named? It is named according to the segmental bronchi supply. So name according to the segmental bronchi supplying them. So let's discuss right lung and left lung bronchopulmonary segments. There are three lobes: upper lobe, middle lobe, and lower lobe. If you're talking about the right lung, first of all, upper lobe. Okay, right lung, upper lobe, superior lobar bronchus or upper lobe for the right lung, having three segments: apical segment, posterior segment, and inferior segment. Apical segment, posterior segment, and inferior segment. It should be not inferior, it should be anterior.
Anterior, yes sir.
I think. Okay. Apical, posterior, and inferior.
Anterior.
If we talk, okay, then if we, let's discuss about the middle lobe or middle lobar bronchus or middle lobe of the right lung. We have lateral and medial segment. There we have lateral and medial segment. Then we have inferior lobar bronchus or lower lobe of the right lung. We have 6, 7, 8, 9, 10. Superior apical, medial basal, it is not visible over here, 7 number. Then anterior basal, number 8. Number 9, lateral basal. Number 10, posterior basal. So these are the 10 segments of the right lung. Let's discuss about these segments, bronchopulmonary segment of the left lung. First of all, again, number 1, apical, posterior, and interior. Apical, posterior, interior. Okay, plus superior lingual segment and inferior lingual segment. Superior lingual and inferior lingual segment. Then we don't have middle lobe for the left lung. We have lower lobe. For lower lobe, same, like again, superior apical, medial basal, anterior basal, lateral basal, and posterior basal. 6, 7 is not visible anteriorly. Then we have 6 for the superior apical. This is the superior apical. This one is the anterior basal. This one is the lateral basal, and that is posterior basal. So these are few bronchopulmonary segments related to the right lung and the left lung. And these segments are very much important for the restriction of the infection. They try to restrict the infection. Suppose if this segment is being infected, it will try to not spread to the nearby segments. But still, exception is always there. There are two disorders. First of all, tuberculosis and carcinoma of the lung. It will definitely spread to the nearby segments. And tuberculosis is the most common cause of cancer. Not a cancer, most common cause of killer in underdeveloped countries. So you're supposed to treat that tuberculosis as soon as possible, because sooner or later it will be the patient will be resistant to the tuberculosis drugs. Okay, if I can show you something related to these segments only, then we will talk about pleura. Okay, I'll do here only. Obviously we have trachea, then we have like this. सही, ये 25 डिग्री का एंगल होगा, ये 45 का, ये छोटा हो गया, वाइडर हो गया, ये लंबा हो गया और नैरोअर हो गया. दिस इज द primary bronchus or principal bronchus or main bronchus. We have two primary bronchus. You can see 1 and 2. Yes. And after this we have 5 secondary bronchus. I will do like this: 1, 2, 3, 4, and 5 like this. These are which bronchi? Secondary. So they are how many number? 5. Total how many segmental bronchi in one human being?
50 to 50. 80.
10. Obviously, if right side is having 5 and left is also having 5. Then these are the primary. These are the primary segment, and these are the secondary segment. After secondary, what we have? Tertiary. How many in one lung? How many tertiary segments we have?
5.
10. These are the 5 for the secondary segments. 10 in one lung. So in one human being, how many tertiary segments? 20. So tertiary segments are also called segmental. Okay, we will do like this. Segmentals, see, these are 10 segments for the right lung and 10 segments for the left lung. We will do like this: 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. You know, I have to understand the conceptually, na? Maybe you can do like this. Do like this. We'll do like this. So these are our tertiary segments or segmental, not tertiary segment, tertiary bronchi or segmental bronchi. We are 10 in number in one lung. And one human being, how many tertiary bronchus we have?
20.
And one human being, how many secondary bronchi?
10.
And one human being, how many primary bronchi?
2.
Obviously. So, okay, thus now these 10 names, we have discussed these 10 names in right lung and for the left lung. And if I can do like this, after these segments, so this is the segmental bronchi. It will also divide somewhere like this. At the end, it becomes, this is segmental or tertiary bronchi, okay? It will divide over here. These are the branches or divisions of the tertiary bronchi. After this, these are the terminal bronchi. After the terminal bronchi, we have respiratory bronchi, with which we have acini or alveoli, where there is exchange of gases will be going on. We will discuss about exchange of gases in physiology of the respiratory system. We are talking about the anatomy. These are the segmental and these are what? Respiratory bronchioles or bronchi. Okay. Let's discuss our last topic, that is pleura. Over here. Pleura is just like a peritoneum in the abdominal cavity, right? Peritoneum is also a serous membrane covered by mesothelial cells. So pleura is also a serous membrane covered by mesothelial cells, specifically flattened epithelium. And there are two layers of parietal pleura or visceral pleura. Parietal pleura is also called outer pleura, and visceral pleura is also called pulmonary pleura. These two layers of pleura, they are continuous around the hilum of the lung. Okay. Okay. Now after this is just okay. We have parietal pleura and visceral pleura, and the space between these two pleura is called
pleural cavity.
Pleural cavity, and there is a serous fluid present in this pleural cavity, about 5 to 20 milliliter.
Yes, sir.
Okay, required in order to prevent the collapse of these two layers of pleura. And two pleural sacs, they are either side of the mediastinum. Called chylo, either side of the. Okay, I can show you. If I can show you. Suppose here we have trachea like this. समझ आ रही है कि नहीं आ रही?
Yes, sir.
So this is the hilum. We will do like this. Visceral pleura will start like this. Visceral pleura is just like our pyometer.
Yes, sir.
What does mean pya?
सर कोलैप्स होता है इस पर.
पाया का मतलब क्या होता है? पाया मैटर, पाया मैटर, ड्यूरा मैटर, रेक्नाइड मैटर. पाया मीन्स मदर. बोल दें. So it is adherent और चिपका होता है, adherent to the lung. And here we have parietal pleura or outer pleura like this. And this is what? Pleural cavity. This is what? Visceral pleura or pulmonary pleura. And this is what? Outer pleura or parietal pleura. Okay. Visceral pleura, first of all. Visceral pleura or pulmonary pleura, it completely covers the lung except along the attachment of the pulmonary ligament and plus hilum. It completely covers the lung except the hilum or the pulmonary ligament attachment. And it is adherent to the lung. Adherent means chipagna. It is adherent to the lungs and there is no separation. And it behaves same way as the lungs behave.
Yes.
Visceral pleura. Let's discuss about parietal pleura or outer pleura. It is thicker as compared to visceral pleura and it is divided into 4 parts: cervical pleura, diaphragmatic pleura, mediastinal pleura and costal pleura. Let's discuss about cervical pleura. Cervical pleura extends 5 cm above the first rib and 2.5 cm above the medial 1/3 clavicle, and it limits the expansion of the lungs. Expansion of the lung. And we have discussed about these things, right? Expansion. Okay, let's discuss some recesses of the lungs. The recesses are the things which are try to expand the lung in our deep sleep. recesses of the pleura. So not we're talking about pleura only. There are a few recesses of the pleura that create a reserve space for pleural cavity. Reserve space of pleural cavity for the lungs to expand in deep sleep.
Yes, sir.
Okay, in deep sleep they give a reserve space for the lungs to expand. And we have two types of recesses: costo-diaphragmatic or costo-vertebral recess, and we have costo-mediastinal recess. If we talk about costo-diaphragmatic or costo-vertebral, it means it lies inferiorly between the costal and diaphragmatic pleura. Okay, it lies inferiorly between costal and diaphragmatic pleura. It lies opposite to the 8th, 9th and 10th rib along the mid-axillary line. Mid-axillary line, 8th, 9th and 10th rib, we have a recess called costo-diaphragmatic recess.
Yes.
Present inferiorly, lies inferiorly between the costal pleura and the diaphragmatic pleura. Okay, इसकी location पता चला. In most important, most dependent part of the pleural cavity, pleural effusion happens at this costo-diaphragmatic pleura. This is most dependent part. If there is any pleural effusion, any fluid in the pleural cavity, जब भी pleural cavity में fluid आ जाता है, कोई blood आ जाता है, पानी आ जाता है, पस आ जाती है, तो it will be mostly chances are there that fluid will store at the costo-diaphragmatic pleura recess only, which is present mid-axillary line 8, 9 and 10th rib. Are you with me?
Yes, sir.
Okay. Pleural effusion, and due to pleural effusion on percussion there will be stony dull percussion. If I can show you like this, so this is pleura, suppose, and due to the this is lung like this, and due to the pleural effusion there will be collapse of the lung like this. Lung will be look like this. It's called collapsed lungs. In any kind of pathology, infection, trauma, tumor,
Yes.
It is also called atelectasis. Collapsed lungs, atelectasis. Here you will put your injection like this, and this process is called cardiac. This was called paracentesis thoracic.
Mid-axillary line.
Okay. Just mid-axillary line 8, 9 and 10.
T4.
Not T4. Mid-axillary line 9, 10 and 11 ribs. More specific, okay. We will not confuse first of all. Costo-diaphragmatic recess present at the level of mid-axillary line 8, 9 and 10th rib. That's it. Okay. Forget about this thing also right now. Let's discuss about parietal, not parietal pleura, we are talking about another recess called costo-mediastinal recess. It is present anteriorly between the costal pleura and the diaphragm and the mediastinal pleura. It lies anteriorly between the costal pleura and mediastinal pleura, and during inspiration and expiration, anterior border of the lung will go in and out of this recess. In inspiration and expiration, the interior border will go in and out, and it is larger. The left side, left costo-mediastinal recess is larger because due to having of a cardiac notch. Due to presence of a cardiac notch, okay, this costo-mediastinal recess is larger as compared to the right side due to having of a cardiac notch. Okay. Then most preferred site for pleural aspiration is 8th intercostal space, mid-axillary line. This is 8th intercostal space, mid-axillary line for the pleural aspiration, and this process is called paracentesis thoracic. And all three lobes of the right lung is better auscultated at best auscultation at mid-axillary line. All three lobes, superior, middle and inferior lobe, having best auscultation at the mid-axillary line. Last but not the least, there are few pulmonary ligaments are made by the parietal pleura only. Parietal pleura surrounds the lung at the hilum as a fold, and it will extend downward. There are two important things for the pulmonary ligament, and these are the same ligaments. As I told you, there are two things. Visceral pleura don't cover. Visceral pleura covers all the lung except two things. One was hilum. Visceral pleura किधर है? Along the attachment of the pulmonary ligament and hilum. This is the pulmonary ligament we are talking about. Parietal pleura surrounds the lung at hilum and make as a fold and extend downward. There are two functions. It provides the dead space into which pulmonary vein can expand, and it allow the descent of root of the lung during inspiration. Two function of the pulmonary ligament. First of all, it will give a dead space for the expansion of the pulmonary veins. Number second, it will descend the root of the lung downward during
Inspiration.
Lastly, we have parietal pleura. It being innervated by the phrenic nerve and intercostal nerve, and visceral pleura is innervated by the sympathetic fibers of T2, T3, T4 and T5, and visceral pleura is pain insensitive, but parietal pleura is pain sensitive. We have referred pain of pleura. The referred pain of central diaphragmatic pleura or mediastinal pleura will shift to the skin of the neck and shoulder. Why?
सर वो क्योंकि नर्व इनर्वेट करती है उधर नेक और शोल्डर को और वही इधर
Yes, phrenic nerve C3, C4, C5, same C3, C4, 5 supraclavicular nerve innervate, also the same things. You can see over here. So referred pain of the pleura, central diaphragmatic and mediastinal pleura will shift to the neck and shoulder because phrenic nerve C3, C4, 5 same nerve root rally for the supraclavicular nerve. So that is why the pain will shift. If the pain is shifting to the right shoulder, it means there is a problem of the gallbladder. We have discussed in the third part of the digestive system. And if the pain is shifting or radiating to the left shoulder, it means it is a splenic rupture. So please don't forget to learn the referred pain also. If the pain is referring to the left arm, medial side of the arm and the chest, it may be a angina pectoris. If the pain is referring to the right shoulder, it may be a problem of gallbladder. If the pain is radiating to the left shoulder or scapula, it may be a splenic rupture. And if the pain is radiating to the skin of the neck and shoulder, it may be a which pain? Pleural pain. Pleural pain. There is another terminology called pleurisy. Inflammation of the pleura is called pleurisy, and oftenly this inflammation will lead to a fluid accumulation in the pleural cavity. That is called pleural effusion. And one of the signs of the tuberculosis of the lung is pleural effusion only. In tuberculosis of the lung, it will lead to the pleural effusion. Not only inflammation of the pleura, but also fluid accumulation in the pleural cavity. And pleurisy is mostly dry. Due to inflammation of the parietal and visceral pleura, the visceral and parietal pleura, they are dry, and due to dryness, this is called dry pleurisy. During inspiration, expiration, there is more friction, and this friction is very terrible and painful. Then last but not the least, we have few terminologies called pneumothorax, hydrothorax, hemothorax and chylothorax or empyema. What is pneumothorax? If there is any air, more air in the pleural cavity, there is pneumothorax. Hydrothorax, more water in the pleural cavity.
More blood.
Hemothorax, blood in the pleural cavity. Chylothorax, lymph in the pleural cavity. And if there is a pus in the pleural cavity, it is called empyema. So that was about pleura, pleural cavity, the lung, bronchopulmonary segments, trachea. Is there anything?
Tracheal potency.
Tracheal potency, the potency, or you can say the strength of the trachea.
सर विसरल प्लूरा और पैराइटल प्लूरा में पेन सेंसिबल कौन सा?
The visceral pleura is pain insensitive and parietal pleura is pain sensitive.
Yes. Effusion?
Effusion simply पानी कह सकते हैं. First of all, if there is inflammation of the pleura, it is called pleurisy, or you can say pleuritis. Again, inflammation of the pleuritis, carditis, gastritis. And it is called pleurisy more specifically. And not only inflammation, more frequently, oftenly with inflammation, there will be fluid accumulation in the pleural cavity also. That is called pleural effusion. And in order to remove that fluid from this pleural cavity, this is called paracentesis thoracic. You can see over here.
Epicora.
The size of left lung is shorter than the right lung.
Not size, weight. Weight is, or you can size also. Size also less and weight also less than the right side because due to having the presence of a heart at the left side.
So, but you told that left lung is larger than right lung.
Again, left lung is not large. You can see you can say, but it's written in book only. I can't do anything.
Sir, epicora. What is it?
Epicora, nasolacrimal duct opens at the inferior nasal meatus normally. But if in increase or immense amount of emotional state or in pain, this nasolacrimal duct becomes saturated with the tears. and the immense amount of tear will not only go to the nasolacrimal duct but also pass through our face sound. That is called epiglottis.
Okay, sir.
What else?
Okay, sir.
Okay, sir.
Thanks.